Then I will go through the WHO recommendations on ACTs, the work which has been done around the doses. I discussed a little bit treatment failure, and also this was one of the points you put in the parking lot, more specifically about ACT treatment failure. And we'll discuss about the treatment of the other species, not only falciparum, talk a little bit of hyperparacetamia and the management of uncomplicated malaria in special risk groups. Again, this was one of the topics you also have pointed in your parking lot. So for uncomplicated malaria, the definition is a patient which presents with symptoms of malaria and a positive parasitological test, which could be microscopy or RDTs, but without any feature of severe malaria. This is what we consider as uncomplicated malaria. Now the child here in the photo has probably prostration, and we should test this capacity to sit or to walk without assistance, because that could be a sign of severity. So this is not maybe the typical picture of an uncomplicated malaria patient, but remember the video which was shared by our Sudanese colleague we saw last time, the video clip of a child. It was a girl. She was very sick, sunken eyes, relatively weak. And we saw also the video after the treatment when she was probably completely well and recovered. So this is what we have as WHO recommended treatments of artemisinin-based combination therapies. Artemether lumefantrine is now the first-line treatment in most countries. Artesunate amodiaquine remains in some countries of West Africa, especially as first-line. Artesunate mefloquine and the other artemisinin piperaquine are two ACTs which are used in Southeast Asia. And then artesunate plus SP is a medicine which has been progressively abandoned by many countries, partly resistance, but also availability. And more recently, we have this new ACT, the use of artesunate pyronaridine, and I will mention the latest evidence around this ACT. So our recommendations are put in the malaria treatment guidelines, which are mainly developed to support policymakers to develop national treatment policy. So it's your reference book. And remember from the first session, it's on your SharePoint. So you have it. And the way is to provide recommendations for medicines which are effective, so high cure rate, but also safe. And they are also in a regimen, in combinations to minimize the development of resistance. And to develop these treatment guidelines is a very complex process. It takes normally 3 years to develop a new edition of the treatment guidelines. As you know, the last was the 3rd edition, and we are at the moment in preparing for the new updates of the treatment guidelines. The way, just very briefly to tell you, the way it's been developed, there are initially one has to look for specific questions. We have to compare an intervention in a specific population and look at a specific outcome. For instance, is the cure rate of artesunate injectable superior to quinine parenteral? And you can define in all cases with severe malaria, or you can also specify children with malnutrition. So you have to define what is the population. And once these specific questions are defined, Then there is a process to formalize this specific list of questions, and then look for the evidence in a very systematic way that will support the efficacy, if the question is around efficacy, or safety, if it's around, again, a specific side effects. And all these reviews and evidence are being then progressively seen by groups of experts, which meet over several times in the process, sometimes even 3 meetings over a time span of 2 or 3 years take place. Then the guidelines are made first draft, then they go to an external review group, they are reviewed finally, and then submitted for approval. So just to tell you, it is a very thorough process. It's not that just a group of experts meets once and they come up with new recommendations. And when we developed the 3rd edition, the recommendations for many ACTs were already well defined. What was new was the specific dose for artesunate mefloquine. This is available in a fixed dose combination, and there are 4 specific treatment courses for all weight groups. And for the artemisinin piperaquine, there was a big work done to look into the children of small weight, and especially below 25 kilogram body weight. And looking at the plasma level, this is for the different levels by age groups. You see that when you start at a specific dose, generally the lower weight bands, they receive a higher dose. And then when the patient becomes more heavy, comparatively to the plasma level, they receive the lesser amount of the medicine. But when this was analyzed for products available on the market, Eurartesin, it was found that below 25 kilogram, what the manufacturer was recommending produced very low blood levels. So the WHO made some studies looking at published studies, compiling all the plasma levels published in these different studies. And they developed a specific modeling to look at what will be the ideal age-specific or weight-specific treatment courses that in order to obtain for each age similar distribution of plasma levels. So, and the results was that what we have in the treatment guidelines is a very specific and adjusted dosage by weight bands, which are different from what you can find in the commercial product available, Eurartesin, or what was available before even that manufactured by a Chinese company. So there are multiple dosage system, but in the recent WHO treatment guidelines, these were reviewed and looked at based on pharmacokinetic data to achieve similar blood levels for both diartemisinin as well as piperaquine. Now, this is coming to this new, relatively the last addition to the ACTs, which is pyronaridine artesunate. It was this is a Cochrane systematic review, which is a publication which looks at all the studies, and this was used by the expert which met in 2017 by WHO. And this review showed that this medicine produced a very high cure rate, above 95%, and so it is as good as artemether-lumefantrine or even better in terms of cure rate. However, this may create an increase in the transaminase, so liver enzymes, above 5 times the upper limit of the normal, which is a sign of mild drug-induced liver injury, and indicating that this drug has some moderate hepatotoxicity. Now, there was never so far documented some serious events, but for this reason, then WHO decided this was to be reviewed by a specific committee on safety of medicinal product, which reviewed in September 19 this medicine, and came up to a series of consideration. I think most important is that at the moment, this was mainly used in clinical trials. Many of the patients were excluded if they have high liver enzymes, and we still have a relatively limited safety data, or here is even stronger lack of safety data, in vulnerable patients in malaria endemic countries, especially with those which have comorbidities. So if you think about a disease which can give hepatotoxicity, we don't have yet a lot of data in natural populations with malaria and potentially other comorbidities. Now, because we don't have yet good safety data in real life situation, there is a need to have a robust surveillance system, and we call this pharmacovigilance. And this should be stable and well-performing in any place where this new drug, which is known as Piramax with a brand name, will be introduced. Now, if you go into the product information sheet, this is a medicine which was approved by the European Medicines Authority. And if you click on this link, you will get into the summary of product characteristics, which is the document that the regulators use to summarize all information which is around efficacy and safety of the medicines. And these medicines was evaluated under a special regulatory pathway, which is called Article 58 by the EMEA, and is not a proper regulatory approval. It is a positive scientific opinion. It means that the drug is reviewed with the same criteria like a drug which is being marketed and sold in Europe, but under this special regulatory approval pathway is going to be marketed not in Europe, but only in malaria endemic country. And if you look at even where this document has been put, is easy under medicine outside Europe. So this is something, remember in your parking lot, many of you wanted to know about the regulatory aspects of medicines. Now, medicines are approved by the national regulatory authorities, and some of them are considered mature regulatory authorities like the Japanese, Canadian, Australian, European, American FDA. And others, regulatory authorities have different level of maturity. This is how now they are called. And when a medicine is evaluated for use in the population of the country concerned, it is looked in a very stringent way. It means that also the manufacturing facility is being inspected to ensure that all quality manufacturing standards are applied. If the medicine is produced for export only, and even if it's produced in Europe, these medicines may not be inspected by the national regulatory authority. So it's not subject to the same requirements for regulation. And this is true for medicines. It's true also for diagnostics. And I give you this example. We have one medicine at the moment, one RDT produced by Access Bio, which is manufactured in New Jersey, United States of America. And because of the COVID restrictions, WHO cannot do an inspection locally on this manufacturing facility. So they have asked the US FDA if they can send their inspectors to look into the manufacturing facility. But because Access Bio is producing malaria RDTs for export only, the US FDA is not making any inspection on that manufacturing facility. So it's very important that when you consider a drug which is being manufactured in US, manufactured in the EU, manufactured in Japan, there are differences if it is a medicine which is going to be also marketed and used in those countries, or if it is a medicine which is going to be only manufactured there but for export in other countries. And as I say, this is true for medicines, but it's also true for the malaria RDTs. Now, when we look into this, it's basically it's like the patient leaflet is the summary of product characteristics, and we read about Piramax in the under contraindication. It says that any patients which have clinical signs or symptoms of hepatic injury, such as nausea or abdominal pain associated with jaundice, they should not be given this medicine. And then if we look into special warnings and precautions, basically it says if the patient is already known to have high liver enzymes, the use of these medicines is not recommended. And they also recommended that the parent or the guardian of the patient should be looking during the 2 weeks after treatment for any emergence of signs and symptoms of potential hepatic injury. Now, under the same heading, they say there is no data available in patients which have hepatitis B or hepatitis C or HIV. And you know that this is quite a big population. Hepatitis B in Africa is around 40 million people. There is no data on the concomitant use of antiretroviral drugs, which may also do hepatotoxicity, use of herbal medicines, patients with malnutrition, and some co-administration with paracetamol may also add on the risk of hepatotoxicity. So there is no, again, data on this. And some patients had also hemolysis following treatment. So there should be some caution in treating patients which have a low hemoglobin at day 0 before starting the treatment. So this is what you should know. When a drug is new, there is some alerts on the safety. And after several years of use with a good pharmacovigilance, with more data, some of this may be alleviated over time. So important for you to know. This may apply with different signs and symptoms to other medicines as well. Now, the treatment failure was also one of the points of your interest when you prepared the parking lot topics. And when we have a treatment failure, this needs to be clearly confirmed. And if we suspect a treatment failure, this should be checked by microscopy or an RDT based on PLDH, because we know that some tests, which the HRP2 detecting RDTs, may remain positive for even 5-6 weeks after the initial infection because of the persistence of the antigen. So if somebody has initial fever, has been treated, and comes back again with signs and symptoms of suspected treatment failure, if we do again an RDT based on HRP2, the test will be positive. So it doesn't really help us to know the cause of the treatment failure. And this is now convention, if there is a treatment failure within 28 days, this is considered a proper treatment failure and a different ACT should be given. But if a treatment failure comes after 28 days from the initial treatment, this is considered a new infection, and the same ACT can be given again. Now, some definitions. Treatment failure is different from resistance. The two are very different terms. Treatment failure is simply the persistence of parasites in the blood or the reappearance of parasites after an anti-malaria has been given. And this could be too many factors. For instance, if there was underdosage, or the patients have poor adherence to treatment, or even the drug given has a poor quality, or there was some drug interaction. This all could be a cause of treatment failure. And then, of course, there is drug resistance. So drug resistance is one out of many etiologies of treatment failure. To understand is it treatment failure, in which proportion is due to drug resistance, we need to do therapeutic efficacy studies. And this is the topic of a full different training course altogether. So we need a proper protocol and we need a proper study to understand this. And when we talk about multi-drug resistance, this is also a term which we can hear many, many times. This refers to falciparum resistance to chloroquine, SP, and a third anti-malaria. So this is a very big problem, and particularly in Southeast Asia. In some countries like Cambodia, we have treatment failures above 10% confirmed by therapeutic efficacy study for up to 4 different ACTs. And the only good thing at the moment is that certain antimalarials, they exert a selection pressure in opposite direction. For instance, mefloquine resistance and piperaquine resistance, they exclude each other. So after several years of introducing DHA-piperaquine becomes totally ineffective because of resistance, but then the parasite becomes sensitive to artesunate mefloquine again. And vice versa. After several years of using artesunate mefloquine is no longer useful, but the piperaquine sensitivity comes back again. So this is what is happening at the moment and keeps countries like Cambodia able still to treat malaria, alternating artesunate mefloquine and DHA-piperaquine. Now, this is some of the, from the global database on drug resistance, the artesunate SP data, sorry. This is, the big problem has been observed in Somalia, and we know that when it's already 10%, the failure rate is too high, and this is the number of studies performed, and many of them actually showed very high failure rates. So that's very good that the country has moved away from this medicine. In other countries, even if the failure rates were still relatively low, it was possible to still maybe continue to use the medicines, but there was a question of availability, and it was probably needed to change and go for AL also in these other countries. Now, for other ACTs, artemether lumefantrine, this is for African countries, and the database needs to be updated, but we still have, in most countries, these drugs are working very well. Artesunate pironaridine, as I said, is highly effective. The problem is more safety. And the DHA-piperaquine is still working with high cure rates, so very low treatment failures in most countries. Now, what do we do with the other parasites? It's possible to use ACTs as well. They work against vivax, malariae, ovale, and Plasmodium knowlesi. But in some countries, also chloroquine can be used. So we have still chloroquine sensitive vivax in a lot of the countries. In areas where there is chloroquine resistance infections, and this is for vivax, especially in Indonesia and many countries in Southeast Asia. In these countries, regardless of the species, the first line treatment is an ACT. And at the moment, it's possible to find a treatment, especially when they are purchased for public sector use, at around 40 to 60 cents of a dollar for a full treatment course of AL. So the ACTs also have become less expensive compared to what they were a few years ago. And at the moment, if treatment of a pregnant women in the first trimester which have a vivax, if it is a chloroquine resistance vivax in some of this area, the treatment should be quinine. So this is based on multiple studies, and especially on vivax, there is a lot of evidence that the drug can remove the blood stages forms of Plasmodium vivax. Clearly, to remove the hypnozoites, we will need to add also primaquine, and this will be the subject of a different lecture I'll give you in another session. Now, another issue is hyperparacetamia. It is defined with 4% and more of red blood cell parasitized. And when it is recognized in the thick film preparation, these patients are at risk to have severe malaria or also treatment failures. And because of the drug resistance developed by spontaneous mutations, the higher is the parasite density, the more spontaneous mutation can occur. So this is also people which could be source of anti-malaria drug resistance. So it's very important to treat them quickly, treat them with good and effective medicines. Now, there are also different levels of hyperparacetamia. If it is above 10%, it's considered severe malaria in all settings. If the paracetamia is between 4 and 10% without signs of severity, this requires close monitoring and, if possible, admission to the hospital, because these patients may have high treatment failure rates. And if there are non-immune travelers, like somebody from Sudan, which has been working in Saudi Arabia for many years, when he comes back to Sudan and if he's found with a paracetamia above 2%, this is also a patient at risk and requires very close follow-up, because he may have a progression to severe malaria or treatment failures. Now, in your list of parking lot, you were interested, many of you, what is the treatment for a child of 5 kilogram body weight? And the WHO recommendations are for children below 5 kilogram, they should be given the same dose of children of 5 to 10 kilogram body weight. And for most ICTs, we have recommended doses for these small children. For HIV, the same treatment applies to give, but only a contraindication is artesunate SP if they receive cotrimoxazole, and artesunate amodiaquine if they take specific forms of ARVs, efavirenz or zidovudin, because they may have a severe neutropenia when they take artesunate amodiaquine. And when a non-immune traveler, I gave an example of a Sudanese working for many years in Saudi Arabia, is really a non-immune traveler. When he comes back home, they should be treated with an ACT when they are coming back, and there is strong evidence of this recommendation.
At this stage in the female's life, a series of behavioral steps begins, which will be repeated for as many times as her lifespan will allow. These will be aimed at finding a suitable host for a blood meal, an adequate place to rest during digestion of the blood, and finally, an appropriate site to lay eggs. These are the activities that most commonly affect female dispersal, which does not usually exceed a few hundred meters per day. Although initial dispersion will presumably be random in relation to the target, the female mosquito will experience a chain of stimulus-response situations as she approaches the host upwind. Chemical stimuli, namely carbon dioxide and host-related specific odors, lead her to the general vicinity of the host. Physical factors, namely warmth and moisture rising from the host, then enable her to home accurately onto the surface of the body. Although these stimuli elicit a powerful attractive response, only some species have developed the ability to bite indoors, overcoming architectural barriers. This clearly provides a great advantage to the mosquito, whose biting activity is, like all other activities, concentrated at night, when most humans and many domestic animals are asleep indoors. In addition, most anophelines are able to discriminate between various hosts because of genetically determined responses to specific host odors. Therefore, although choice also depends on the availability and accessibility of man and alternative sources of blood, zoophilic species feed predominantly on animals, while anthropophilic species prefer humans. This, of course, has a fundamental impact on the efficiency of a species as a human malaria vector, because the higher the frequency of biting on man, the higher the probability that a mosquito will pick up a plasmodium from an infected person, or that an infective mosquito will transmit the parasite to a new host. Once a female mosquito has landed on a likely host and has chosen a suitable site for penetration, she thrusts the proboscis directly into a terminal blood vessel and injects saliva to increase the local blood supply. If she is infective, she will also inject malaria parasites. The female mosquito may ingest blood up to more than twice her mean unfed weight and load her stomach to a point that part of the plasma is excreted from the hind gut. If the blood meal contains infective gametocytes, the mosquito will become infected and later infective, depending on its receptivity to the ingested plasmodium strain and the climatic conditions prevailing in the resting place. In an optimal tropical environment, Plasmodium falciparum will need the mosquito to survive at least 9 days after the infective blood meal in order to complete its cycle. The blood meal is essential to the female, as it provides both the
I just will move it now to another session of the video, so that we will get the core elements for the next two presentations. Okay.
Have been laid, the female is ready for another blood meal and for the development of a new batch of eggs. The number of times a female mosquito will bite is thus a function of both her longevity and the length of the gonotrophic cycle. As the mean longevity of an adult in tropical areas is 2 to 3 weeks, and the eggs take about 48 to 72 hours to mature, we can expect each female to bite up to 8 to 10 times in her life. If she takes the first blood meal from an infective person, the last 2 or 3 bites will transmit the malaria parasite.
So this is just to give us an introduction to the use of medicines to interfere with transmission, and particularly the use of primaquine. The parasites we are fighting, they survive in different ways. Falciparum has a very high level of parasitemia, especially when somebody is sick, is symptomatic. And this is the light microscopy threshold when after even treatment, the parasitemia goes down, and people have special immunity. some infection may continue to have a parasite at very low level for a long period of time. Now, vivax has a different altogether strategy to survive. It after the primary attack, it can give relapses, and some of them also cause febrile illness and are detected by light microscopy. But in sometimes they may occur over time and present at very low parasite density. So even below the threshold that can be seen by light microscopy. Remember that below 20 parasite per microliter, microscopy is not a good test. So whatever we use, microscopy and RDTs, there are some infections that we are not able to see. And we don't know how much are they. Are these a majority? How do they contribute to the transmission? And are they important so that we need strategies to detect them? For instance, in the Cameron Island, they were trying to target all infections using RDTs, but RDTs also have a limit of detection, maybe around 50 parasite per microliter. So are we missing with this strategy a lot of the parasite which contribute to transmission? And there is a relation between the positivity rate by microscopy and positivity by PCR. And it's not on this dotted line, it's not a one-to-one relation. But actually, if you use a study and you measure by microscopy, you can only detect half, approximately 54% of the infections which are detected by PCR. So you almost can double your number of infection by using PCR. And these submicroscopic infections are more common in adults, clearly related to immunity. So if you look at the same relation in below 16 years of age or above 16, there is much more infections which are detected by PCR, but not detected by microscopy. And also, if we look for gametocytes, which are the form to transmit malaria, the gametocyte rate that we can measure by microscopy is even below 9% of that we can measure by PCR. So microscopy underestimates a lot of the gametocytes which are present in the blood. So we have multiple types of molecular methods to detect infections. The most conventional is the nested PCR. Remember this Sudanese paper on HRP2, they were using nested PCR as their standard. This is the typical and has a limit of detection of around 6 parasites per microliter in blood spots. So if you collect the blood in this dry blood spot, below 6, this is not a good method. Now, there is also something which is called multiplex PCR, which can detect multiple species at the same time, has a very similar limit of detection, but you can run many more samples per unit of time. Then more, let's say LAMP, this is very common, also very well known. It has a little better in sensitivity. Results take some time to get, half an hour. And you are getting even below the conventional PCR level. Very expensive, so really didn't have much of a commercial application as a technique. Then if we want to go to really more sensitive, one has to use quantitative PCR or QT-NASBA, and they have a limit of detections which are even 100 times below the conventional PCR. And this is also the QT-NASBA, very good for detecting gametocytes. So we have many techniques And we have multiple approaches to look at very low parasite densities. Now, if we compare over parasite density, the distribution of infections which are detected by microscopy, this is the red line here, and we compare those which we can detect by PCR, but not by microscopy, you see that the PCR can detect a full set of infections which are much at lower parasite density. Also, if we look at those which are PCR and microscopy positive, and we look at the percentage of the individual which are detected, they are detected at a relatively high parasite density. But if we use PCR and look at those which are detected at PCR but not by microscopy, we can detect a very high proportion of positive at a much lower level of parasite density. And if we look at those infections which have gametocytes able to infect mosquitoes, and if you look at their percentage of infections with detected gametocytes, those which they are relatively higher and probably more closer to the positivity by microscopy than the positivity by PCR. So this means that those infections which are more infective to mosquitoes are those which we can see more clearly on microscope. And even if the microscope will not see the gametocytes, you saw that only 9% are detected by microscope, so actually are detected by PCR, those low-level gametocytes are not able to infect very well the mosquitoes. Now, so how many are these low-density infections? And this is taking different level of transmission detected by PCR. So this may correspond up to 5% by slight positivity rate. This may be 10% slight positivity rate. This is more than 10%. So these are the data given by PCR positivity. You see that this is number of studies done at this the level of transmission. In areas of low transmission, so below 10% slight positivity rate, the majority of infections are low density infections. And this is true for falciparum, but is also true for vivax. So a lot of what is present in the population is there, but if we do a survey by microscopy or a survey by RDTs, we are not going to see them. It's not available, it's not seen, it's not detected. But again, this is not true everywhere. And Sri Lanka has been an island where malaria was extremely low for more than 10 years. And they have done a lot of surveys, and this was published in the American Journal, over a long period of time, look at 2003, 2007, even in the areas where you had the highest records of transmission over time, they were not able to detect asymptomatic infections, PCR positive. And Sri Lanka was finally eliminating malaria 10 years later, this type of surveys. So it's possible that these low density infections are present in areas, but after long period of time, after 10 years, they may tend to disappear. So remember this tail for falciparum over time. Is possible that after many years of low transmission, the percentage of PCR positive, microscopy negative infections are no longer present in the population. And when we want to look at efficacy of medicines to interfere with the transmission, we use some experiments called skin feeding. If we apply mosquitoes on patients which have taken special medicines like Primaquine, or we use membrane feeding. If we take from a patient who have taken Primaquine, we take blood and then we put it on a membrane in a special container, and we allow then mosquitoes to feed on this blood through the membrane. And this is probably more complex studies where we want to look at the protective efficacy of antibodies, or especially there is this immunotherapy or a vaccine, and see what is then the impact of immunotherapy or a special vaccine on the infectivity of the gametocytes which may be in the blood, using again membrane feeding experiments. So what do we do on this mosquito after there has been this blood feeding? The mosquito is taken under a stereoscope, and then using some needle, is the part of the abdomen is taken out, and then the inside, the gut of the mosquito is stained and put under a microscope to then stain and count, then detect and count the presence of oocyst. The same operation can be done with another dissection here on the salivary gland, and look under the microscope the presence of sporozoites in the salivary gland of the mosquito. So these experiments are done to look after giving a drug to a patient, what will be the impact of this medicine on the gametocytes, which are then given through a membrane to mosquitoes, and then looking at sporozoite or oocyst, one can study their capacity of this medicine to interfere with malaria transmission. So this is some of the results of this type of experiments. Some patients were given Primaquine, single dose, and 24 hours later, then the blood was taken from these patients and given to mosquito for membrane feeding. And these were the number of oocysts before the treatment in some control mosquito. And if one looks at the oocysts in mosquitoes, which were, two groups of mosquitoes, one which were feeding on the patients before they were taking Primaquine treatment. And if you do the membrane feeding experiments and wait for some time and look at oocysts, you find a lot of them have oocysts in the gut. If, on the contrary, on the same patients, they are given Primaquine single dose, and 24 hours later the blood is taken, and the mosquitoes are then another sample left to mature over time in the insectarium, and then one looks at the percentage which have oocysts. Very few of them have oocysts in the salivary gland. On the same patient, it's possible to look at the presence of gametocytes in the blood and making a comparison with microscopy before receiving Primaquine and after receiving Primaquine 24 hours later, and you see there is basically no major difference. So Primaquine single dose, when it's given, it doesn't really kill very quickly the gametocytes. Those are still present in the blood. But what it will do, it will affect very strongly the infectivity of the gametocytes inside the mosquito. so they don't produce oocyst. And this is another set of experiments, and done with multiple studies. Within each of the studies are number of mosquitoes which were feeding on patients through membrane feeding experiments. Here are results of the after on the oocyst, and here is the positivity on the sporozoites. And if we look at what happened on mosquitoes which were feeding on the blood 48 hours after a patient has taken Primaquine, one can see some patients were receiving ACT plus Primaquine. These are in the green circles. Some of them, they were receiving only Primaquine without the ACTs. And you see that if a patient was receiving ACT plus Primaquine, and Primaquine at 0.25 milligram base per kilo, which means 15 milligram for an adult, very few of them will develop oocyst. And even if you give half of this dose, very few of them, and even a quarter of this dose, you divide again by half, very few of them are developing oocyst. And the same you will find for the development of sporozoites at the single low dose of Primaquine. When you give with an ACT, very few of them will have then sporozoites in the salivary gland. Even if you reduce this amount by half, you have the same also effect. So on this basis, WHO now recommend a single low dose Primaquine to reduce the transmissibility of falciparum gametocytes. And this is applicable in low transmission areas. And to give it together with an ACT to patients with falciparum malaria to reduce transmission. And clearly there are some people which should not receive Primaquine. This is pregnant women, infants below 6 months of age, and also women which are breastfeeding infants below 6 months of age. And with this low dose, the testing for G6PD is not required because the level of anemia observed is very small. This is different if you have to give Primaquine for 14 consecutive days, then clearly for those, you need G6PD testing. Now, based on the data review, there is evidence on the safety and efficacy to support the deployment on large scales of a single low dose of Primaquine as falciparum gametocytocidal drug without G6PD testing. And this is true for areas which are under elimination or areas which are under the threat of artemisinin resistance.